I'm Dr.Bancha from Thammasat, University Bank of Thailand. So I'm talking about the tips and tricks in arthroscopic subacromion decompression and ACJ resection. Thank you for the committee, Vijay, for inviting me this time. And this is my first time to Delhi. I've been everywhere in India except Delhi, my first time. And the weather is very cool this morning. Very happy. Left shoulder pain. So this is the clinical signs when you see the patient have impingement and loaded the cup. It's always come together. Okay. Complete side and the near test. Make sure that the patient have no stiffness. Sometimes you misinterpret. You try to lift up, but it's painful because the patient has stiff. That we call the terminal stiffness. So make sure you take the range of motion first before you interpret that the patient has impingement side. Okay. So many literatures nowadays they mention about no need to do the acromion decompression. That is wrong. That is wrong. Not always. Okay. You need to judge one by one. Like this patient, you see, they have a very sharp spur like this. So this is your mother. Will you decompress or not? For sure. So if the patient have this kind of acromion and they have bursal side tear and the patient have painful click when you move the shoulder, you can put the hands on elevation, turn, rotation, and you have painful click underneath the acromion. That is the acromion at least. You need to decompress. Otherwise, if you repair the cup, it will torn again. Okay? So don't believe the European literatures. This is always true. They said no need to do decompression. You just repair the cuff. I totally don't agree. You need to judge one by one. Okay. So first, most of the time, if you use this simple X-ray, you will miss the acromion. Okay, you see that. But there's some hints. You see some sclerotic here. We call the sucil sign. And supraspinatus outlet view is not a good view because the clavicle will be in the way. Will obstruct. You cannot see the spur because the clavicle obstruct your view. Okay. So if you just tilt the beam down 30 degrees, in the same patient, you see that? You see the sharp hook acromion spur going down, and this make this space very narrow. Okay. So I prefer to use this caudal tilt wheel or Rockwood wheel, 30 degree tilt down. You can see the spur very nice. This is the degree classifications, okay? But in the real practice, it's difficult to see the tip of the spur because it's depending on the technician that performing the X-ray. So, when should we do the acromioplasty? So, if the patient have type 2 or type 3 acromion, okay, if type 3 there's 73% of cuff tear. So if the spur like this, I always performing the acromion decompression. Or when you see the fraying or fragmentation of the CA ligament, or you have the bursal side tear like this. Okay, bursal side tear is almost always associated with impingement. Okay, so this is my indication to do the acromioplasty. So if you see the tear like this, intact articular surface, and there's a tear, small holes in the bursal side. Okay, this situation you should do the decompression. The goal is to change type 2 or type 3 into type 1 and create more space for you to work for the subacromion space and leave delta attachment intact. Okay, so that is a goal. So I perform the Rockwood view 30 degree caudal tilt. So how much you will do the decompression? Look at the X-ray, not MRI. MRI cannot tell you because you are looking to see the bone. Okay. So in this spur, you draw the line from the distal clavicle, make a straight line to the base of the spur, and this is the spur that you need to resect. Okay. So I will draw this line. So it will be this spur that I need to resect. But this picture is exaggerate because you tilt the beam down like a shadow. You have the shadow. Shadow is longer than your height, right? So this image just tell you the morphology or the shape of the acromion, okay? But did not tell you the real size of the acromion spur. Understand? So when you go in, you need to find the landmark. For this acromion type is hook or Q type. You find the base of the spur and also find the distal clavicle. I draw the line from distal clavicle. And this, you see, is this the same image you see in the X-ray? Okay, this is hook, you see? It's the same shape like we saw in the X-ray. Okay, this one, you see, it's the same shape. This one is irregular type spur. Also, we draw the line from distal clavicle. Okay, also this one, okay, you draw this line. This is easy. You have the base of the spur, it's like comma. So you draw the line from the comma and make it flat. Okay, like this. So this is Dr. O classified the shape of the spur in rotator cuff tear. They found that this type we call the heel type. Heel type is going straight down like a heel of the shoes. Okay, this most common associated with the rotator cuff tear. Okay, so they have the medial type osteophyte, traction osteophyte, and bird beak osteophyte. So this type of osteophyte you need to decompress. So we propose a new view we call the TU or Thammasat view. This view can predict the size of the spur. Okay, because a rockwood view you just tell the morphology, but you cannot tell the size, the real size of the spur. Okay, so you need to make a 30 degree tilt caudal and 40 degree perpendicular to the acromion. Okay, using this view you can tell the real size of the spur. So when you go in, you always see this abrasion or fraying of the shear ligament. Do not cut it, just peel. Okay, use the RF to peel this spur, to peel this ligament from the spur. Okay, and keep the lateral side of the ligament attached. See that? This is a tip, but I will preserve this part because the CA ligament have two attachments. One is to the spur and another attachment is to the lateral side. So keep the lateral side intact. Okay, and after that we find the base, okay, of the spur. Okay, I draw the line. This is clavicle. I draw the line from clavicle. Okay, so and marking with RF. So this is a spur that I will cut it. Okay, and then we start to cut it. If you didn't detach the CA ligament, after you cut it, the fragment of the bone you dropping down with the CA ligament. So first peeling the ligament, find the distal clavicle, and then cut it parallel to the part of the distal clavicle. Okay, and make it flat like this. And always see both views. So now you're looking from posterior. After you finish, you need to switch your camera. Okay, don't forget to take the lateral bevel also. Sometimes the acromion is projecting down and have some downslope. You need to cut the lateral end, okay, to reduce the acromion index. Okay, make it flat like this. Okay, and then I always cut my lateral part of the acromion. We call the lateral bevel. Okay, stop the breathing and check again. And then you switch your camera from posterior to the lateral side. Now it's like you're looking from lateral. Okay, clean the roof again. Okay, make sure that your acromion is completely flat. You see, now your acromionizer coming from the back. Okay, and you use your posterior acromion as a reference and completely cut it like this. So your acromion will be flat in both views. Coronal view, you use the distal clavicle or the base of spur, and lateral view, you use a posterior part of the acromion to make it like flat. Okay, this way. Very important. If you didn't switch, you see the acromion only one view. It's not the three-dimensional view. Sometimes you miss the spur. Okay, so very important. Keep the deltoid attached. Do not detach the deltoid too much because you will detach the insertion of the deltoid. The patient will be painful. Okay, and do not transect the CA ligament. Just release it from the acromion spur. Okay. okay, like these patients. Okay, you draw the line this way and cut the acromion spur this way, like these patients. Okay, after you cut, you will see that the line from the distal clavicle is parallel to the acromion. Okay, I prefer to do bead share. Okay, because I need to rotate. I'm working on the rotator cuff. Okay, I need to rotate. It's not like instability. I prefer to do in traction positions. But for rotator cuff, sometimes you need to go to the front. Sometimes you need to put the anchor from the front. You can rotate the arm. You can external rotate. You want to put the anchor in the back, right? So for me, I prefer to do it in bead chair position. Okay. So first, we make a drawing. Very important. Okay, especially a very big size lady, you need to make sure that you palpate the bone, not the soft tissues, because you make a long portal placement. Like you put portal too high, you're working above the acromion. Very important, you cannot get underneath. Okay, so my portal will be, for routine rotator cuff, I have 4 portals. Okay, the first portal is okay, this is acromion. First portal is about 2 centimeters and 2 centimeters down. First portal. And the lateral side, I have 2 portals. One is my working portal. It's about 1.5 inch from the lateral border. Another portal is posterior 1/3. You divide the acromion into 3 parts. Okay, posterior 1/3. This is for looking. We call viewing portal. You should looking from a very high, right? So you can see a wide view. Okay. Another portal. This portal I use it for suture management and also for the ankle placement, especially lateral low. Okay, I use this for lateral low. And this another portal is just in front of AC joint. This portal you can do AC joint resection, you can do bicep tenotomy, and also you can put the anchor using this portal. So this portal must be very high, just next to the AC joint. If you put it not close to the AC joint, you cannot put the anchor because it's too parallel. Okay, make it very high. So routinely, these 4 portals you can do double row repair. Okay, it's different from the lateral decubitus because you make a lot of step incision when you put the anchors. But for bead chair, you can use the same portal, okay, for many purposes. Okay, and if you need to do some subscap or bicep tenodesis, I will have another portal, okay, here for the subscap repair or bicep tenodesis. So this conclusion of my portals. There will be 4, and if you need to do bicep tenodesis, I will put another portal here, okay, or subscap repair. Okay, these 2 portals is the same portal you do bank cut. Okay, bank cut you have 1 here and 1 here just above the subscap, right? So this already show you how to detach the CA ligament. Okay, slowly peel it off from the bone. Do not cut it. Okay, you fry the border, fry the tip. Okay, slowly, and always you can keep this CA ligament. You see this part is still attached. This part, see? So you don't have to cut it. So this ligament is like a static stabilizer to prevent the superior migration. Okay. Okay, like this. Okay, I will show you. This is a fraying of the acromion of the CA ligament. Okay, and after that you switch. Okay, after you clean, you cut the acromion spur, then you switch your portal from posterior to lateral. Okay, to check again. Okay, I already show you how to do that. Okay, we call like a co-planing. Okay, cut it parallel to the posterior acromion. Okay, also you see fraying like this. Yes, fraying like this, I always do decompression because that means the head and the roof, there's some friction between head and roof. Okay, need to clean it. But if you need to do AC resection, I also clean my capsule, infrared capsule of the AC joint. I'll tell you later. Okay, keep this part. See, keep this part of the CA ligament, and this is the spur. Okay. So clean it this way, but you see that there's some mistake. You clean it very nice, but there's some spur at the distal clavicle. So if you see the spur at the distal clavicle, you should clean it also, because that is still also fight projecting down. So you should clean it completely like this. Okay. There's some complication that refer to me because they cut the acromion too much. Okay, because they didn't know this concept. When you turn the camera up, the arrow get up, you see, oh, there's a big bone on the top. But actually that you're looking up. So the complication always happen because they clean too much. It's like a dome, resection too much. You see that? The acromion is gone. See? A lot gone and it's broken finally. So we need to put the bone graft and fix it. Okay? So this is serious complication. So after you clean the roof, then you do the bursectomy. This is a very important step. I will mention again in my rotator cuff repair. Okay, very important step. Okay, clean the bursa because I think cuff repair you have only very limited space. Very important is to make a good exposure. Clean the roof, bursectomy. Okay, before you start to repair. Okay, sometimes it's bleed, so you need to clean, stop bleeding. Sometimes take you some 10-15 minutes to do this. Okay, not to hurry to repair the cuff right away. Okay, make it clean. Okay, and no bleeding before starting to clean the cuff. Okay, and after that, after you do the decompressions, the next step you need to judge the patient needs AC resection or not. So depend on your preoperative examination. Palpation, very important. AC tenderness, cross body adduction, right? And O'Brien test. So these three tests is the examination I use routinely for my AC examinations. Okay. So the way to do AC resection, you need to keep this superior capsule. Okay. Do not cut this superior capsule. If you cut the superior capsule, the clavicle will move. You have unstable. They will move in horizontal plane. So keep those superior capsule and also the posterior capsule of the AC joint. Okay, you can sacrifice the inferior capsule because you need to come from underneath. You need to clean the inferior capsule to see the superior capsule. Okay. Yes. So after you clean, this is you clean the acromion, lateral bevel. Okay. Then switch your scope to see the AC joint. Okay. Put the spinal needle in. Okay, you're marking. This must be parallel to the clavicle. I make a dilator. Okay, and then you can put the small cannula or not. Sometimes you don't need the cannula. You see that's AC joint, but very important. You need to, if you want to do the AC resection, your posterior portal should be a little bit close, a little bit medial. If you're too far lateral, you cannot see the AC joint. Okay, and then put your instrument from the front. Okay, clean the distal clavicle, but you should not cut it more than 7 millimeters. You go more than 7 millimeters, the AC capsule, AC ligament will be detached. Okay, that's the anatomic study. Okay, after you clean, you see that that's still also fine on the top. Okay, slowly go in. Parallel to the clavicle. So the portal placement is very important. Then you stop breathing. Sometimes there's breathing. Remove the disc. Sometimes there's the discoid tissue in the AC joint. You remove them. Remove the tissue in the AC joint. Okay, and then we check again. Okay. Good. Make it parallel, distal clavicle, the acromion. Okay. So this is another patient. We clean. Okay. See the AC capsule. Okay. Remove the inferior. Also fine. Remove the inferior capsule. So you see the superior capsule. But in some situations, you need to do open. Some patients that have very big osteophyte on the top, you cleaning from underneath, sometimes it's not successful. So in that situation, I will make a small mini open cut the distal clavicle, repair the capsule back. Okay, very effective. Okay. Okay, do not like this. You should see the superior capsule. Okay, distal clavicle clear. Okay, it's about 7 millimeters. You can check again intra-op by cross chest to see that is there any contact between the clavicle and the acromion. Okay, like this. So take-home message: good radiographic can be a guide for intraoperative decision. Rockwood wheel or TU wheel is my preferred. Okay, to check the acromion morphology. Acromioplasty both in AP and lateral. Okay, and don't forget the clavicle is a reference for your subacromion decompression. Not too much resection that can lead to fracture or complication after surgery. And superior posterior capsule should be preserved, okay, in AC resection. Thank you.